Thank you so much for taking the time to be with us tonight. I know there's a lot going on in the world right now, and a lot of stress is going on, but we were talking a little bit before this call that, it's nice to be able to think about the things that we are working towards as students and trainees in healthcare, no matter the field that we want to go into. And we are so excited to have some really amazing speakers with us tonight. I just wanted to take a moment to go over a couple logistics before I hand it over to our moderator, Parisa. The big thing is, unfortunately, right now, all your microphones are muted, so please do chat function if you want to send any questions, or tweet at us and tag the GSSA account on there. And if you have any follow-up questions after that, feel free to email the GSSA account as well. Okay, and I'm going to hand it over to Parisa Fallah, who was the previous co-chair with me of GSSA and the founder of GSSA, who will be hosting our talk tonight, as she will be soon to be resident OBGYN starting in July.
Hi, everybody. Really excited to see such a great turnout for this. Huge passion for bringing together the fields of OBGYN and global surgery, and really excited for our wonderful panelists tonight. So I'm actually just going to start off. So we're going to start off with Dr. Barbara Levy, and I'm going to introduce her before she speaks for a few minutes about her work. Okay, so Dr. Levy is a lifelong advocate for advancing the quality of women's health. Serving as the Vice President of Health Policy at FACOG, Dr. Levy directed the expansion of the Advocacy Division to support the Office of Global Women's Health, reducing maternal mortality and building sustainable capabilities in several countries. Dr. Levy was the principal investigator and oversaw the development and implementation of the Alliance for Innovation in Maternal Health, or the AIM program, while she was at ACOG. Under her leadership, that initiative grew from an initial commitment to 8 states to the current AIM-2 activities designed to reach all 50 US states, as well as the US territories. She led the strategies and health equity team to advocate for access to comprehensive women's health services throughout the world. Her work through the AMA has improved payment policy for OBGYNs, while the division's quality and safety initiatives improve systems of care for women, particularly within the AIM program to reduce maternal mortality. Dr. Levy graduated magna cum laude from Princeton University. She obtained her medical degree from the University of California, San Diego, followed by an internship and residency at the Oregon Health Sciences University. Prior to ACOG, Dr. Levy was in private practice and served as a medical director for women's and children's services for the Franciscan Health System. Dr. Levy served 2 terms as chair of the American Medical Association Resource-Based Relative Value Scale Update Committee, advocating for fair payment for physicians, and she is currently an editorial panel member for CPT. She has served as a reviewer and editor for several medical journals, including Obstetrics and Gynecology, the American Journal of Obstetrics and Gynecology, JAMA, JMIG, and Fertility and Sterility. Dr. Levy has been a vocal advocate for women's health with appearances on The Oprah Winfrey Show and multiple other media outlets, and she has published and co-authored over 85 studies. So we're extremely excited and honored to have Dr. Levy here tonight, and I will turn it over to her to share about her work.
Well, it's not my work, it's our work. And thanks very much, and congratulations on finishing med school and getting started in your career. We're really, really excited for you. I'm going to be really brief tonight because we're starting a little bit late, and I just wanted to lay some sort of general principles about the things that, as we were expanding our global work, and we began to call it glocal work, so global and local, because it's very clear that a lot of these principles are as important in our work in the United States and in rural America and in underserved communities as they are in the global community. And so the first thing is to focus on sustainable change, and it's evidence-based, partner-driven sustainable change in improving the delivery of healthcare for women. So what that means is not top-down approach, not walking in someplace and saying, we know what you need and here it is. It is walking in and saying, what do you think you need and how can we help you? And how can we help to build the resources that will enable you to then sustainably deliver the care for the women you serve? And that's a very different approach. Some of our colleagues from I would say the Royal College of Obstetricians and Gynecologists, who've been very involved with global health for a long time, come in a very different way. And it is their mechanism, their test, their goals for education. But as I approach that work, I don't know what an OBGYN in Ethiopia needs to know or needs to be. Their healthcare delivery system is entirely different from ours. The whole structure, certainly of obstetrical care, almost all the babies are delivered by midwives, not obstetrician gynecologists. So curriculum and education and everything has to be driven at the local level. And it has to be our job to enable our colleagues, professional associations, and others to do the work that they want to do. So the set of principles that the Office of Global Women's Health really came up with were several, and I just want to go over those with you because I think it forms a framework for what my colleagues are going to talk about. But number one is that we will do no harm. And I think that's really important for us to acknowledge that sometimes when we go in and we're culturally insensitive, or we bring teams of people in to do service delivery for short periods of time and then we leave, that we may be doing harm. We will embrace the complexity of practice of medicine and respect differing cultural perspectives and differing paces of change. So we're used to a pretty rapid pace of change. Like when we start to do a project, we want to see it through. And that's not culturally appropriate in many places. And things take a long time. We will promote health equity, quality, and dignity for all women. And as we look at care across the world, it's very clear, both in this country and elsewhere, that women are not necessarily treated all that well. We will promote reproductive health and rights, access to services, and freedom of women to make informed, autonomous decisions. Once again, a key point here. We'll catalyze systems change and health systems strengthening and refrain from one-time interventions. And that was a foundational kind of change in mindset. So many of us want to do good, and for us, doing good often meant mission trips or other things where we went off and delivered babies for a couple of weeks and came back. And I think this is a different perspective, that we're really trying to catalyze change in systems. And Lina, I know you're going to talk about that as well. But we'll endeavor to provide training and educational materials and guidelines in appropriate local languages and appropriate to care delivery systems as they exist. We'll prioritize science and evidence in decision-making and program implementation. We'll foster interdisciplinary partnerships with other healthcare professionals to advance multidisciplinary teams. And this is something that, especially in parts of the world where the British were for a long time, it's very hierarchical, and it's not driven by the kinds of team-based care and care bundles that we're trying to implement in the US. And we've seen some real success in embracing the voices of midwives, of nurses, of other healthcare providers in driving that system change. And then our activities will align with the 2030 Sustainable Development Goals. So the activities needed to be aligned in a way that made sense with respect to all the other organizations that are out there working. And one of the challenges in doing global work is that sometimes we would end up in a place in Uganda or in Ethiopia, and there would be 4 universities and 3 other NGOs working in the same place, nobody knowing what the other person was doing. And so trying to coordinate those activities in some way is, I think, a challenge for all of us, but something that we should really definitely try to do. So I think I'll stop there. There are some really exciting programs that we were able to do with professional associations to try to build capacity, to drive curriculum change based on what others wanted. There are a lot of structures in the US that have turned out to be reasonably beneficial to quality medical care here, one of which is a coordinated curriculum, that if you go to medical school at Harvard, or you go to medical school at Yale or Stanford or University of Alabama, your curriculum is not all that different because we have national examinations and everybody teaches to those. So going into a country and saying, what are the key things that a medical student should know when they graduate? And then what are the key things that an OB/GYN resident needs to know to be a competent women's health professional in that country? Building the curriculum and then helping that become universal across a country was an exciting bucket of work that we did.
Much, Dr. Levy. If I could add just one quick follow-up question before we move on, I'd love to know, I think many of us would love to know more about how, ACOG is potentially partnering with equivalent professional OB/GYN or surgical professional societies in low resource settings. And if you could expand a little bit on that, I think that'd be really interesting.
So again, we were looking to be invited, not to impose ourselves on others. So we did develop a relationship with the Ethiopian Society of OB/GYN. They asked us to come in and help them with a set of activities. We did that by inviting them to the US, and then we went there. We had a series of meetings where we had, things all over the walls talking about what the ideal world would look like and where they could really use assistance. And we developed the pillars that we were going to work on. One was definitely curriculum, both undergraduate medical school curriculum and residency curriculum. It was a system like the RRC, where people from their professional association went out and looked at the hospitals and made sure that there was adequate equipment and teaching and all the things that the residents needed. We developed actually an in-service examination with them, helped them understand how to write questions and do those things. We administered the examination. We got, so there was a lot of really fun work. We developed incredible relationships with people, and hopefully that will be ongoing. So we're looking to do that kind of strong work. We also help them become strong vocal advocates with their Ministry of Health, so that the examination that they ended up writing became the national exam to become an OB/GYN in Ethiopia.
Very cool. Thank you so much for sharing that. Really exciting to have kind of like that policy professional society overview to the global health efforts for women. Thank you. So I will move on now to Dr. Valeria Macias, who's joining us, from Chiapas, Mexico. So Dr. Macias has been part of Partners in Health since 2012. While working as a rural physician, she realized the important need to strengthen referral systems. So she was hired to start and coordinate the right to healthcare system. During her years coordinating the program, the hardest referrals that she was noticing were surgical referrals. So she later went to do her master's in global health delivery at Harvard Medical School. When finishing her master's, she returned to Compañeros en Salud as secondary and tertiary care coordinator to direct the maternal home, the Right to Healthcare program, and start a surgical program in coordination with the Ministry of Health. Currently, Dr. Macias continues fighting against social injustice and helping strengthen the healthcare system as the executive director of Compañeros en Salud. Thank you so much, Dr. Macias, for joining us. And I actually remember seeing one of your presentations, I think at the Thune Roundtable, maybe a few years ago. I met you there. So really exciting to see you again.
Well, thank you. Can you hear? Yeah.
Yes.
So thank you so much for the invitation. It's an honor for me to be here today and having so many people listen to us, even though we're going through this huge crisis all over the world. So yeah, sharing with you, I think I started my path in global health without even knowing I was doing global health. I am a Mexican physician, so I finished medical school, I went to do my social service, and I just really wanted to be a rural doctor. So I looked for a site that would allow me to be part of a community and become the rural doctor. So I learned about this organization called Compañeros en Salud, which I learned afterwards that it was part of a big organization that's Partners in Health, and we're in 11 different countries at this moment. So at that point of time, I started learning what global health meant, and that being a rural doctor was just not about, you know, giving medicine to people in rural communities, but actually seeing a lot more of the social determinants of health and learning how to address not only the person and their condition, but the whole society around it to really be able to deliver good quality healthcare. So while I was there, definitely my biggest frustration was surgeries. I live in Mexico, and we live in an upper middle income country, but as in many countries in Latin America, there is a huge disparity amongst people in Mexico. So we have people that have a lot of access to healthcare, but then we have people like people in Chiapas, which is the poorest state in Mexico, that really struggle every day to have access to quality of care. So one of those things that was just really challenging to always help my patients to was surgery. So I was in a primary care clinic, and Partners in Health gave me everything I required to give primary health care, but then there's a point as a family doctor where you can't do anymore. So the need of surgery was just really, really important. And that's why we started the Right to Healthcare program, which is a referrals program. So we live in a country where there's already a healthcare system, and there's already secondary care and tertiary care and primary health care, and there's a lot of physicians in theory, but when we're talking about delivering care to the most vulnerable population, then how do we bridge that gap amongst what already exists in the system and what these people can really get access to? We were talking about a country that even said that we had universal healthcare coverage, but even though you had a universal healthcare coverage and you were entitled to receive care, that doesn't mean you're really getting the care that you were entitled to. So the Right to Healthcare program tries to strengthen that gap by using physicians and acompañators or acompañantes, we call them, to accompany the patient to the secondary and tertiary care system and make the system work. So at the beginning, I was like, well, maybe it's just about, you know, giving social support, food, transportation, and then people can actually access healthcare. But then I realized it was a lot more complex. Sometimes when systems are already built, but there's a lot of bureaucracy in the middle, and there's so many gaps, how do you put the system back again together so that it can really work functionally and efficiently, so that people can actually get access to care? So I think in Latin America, we're all going through this, I'm gonna call it like patch system, in where there are certain things that work, but there are so many things that don't work. And how do we strengthen that healthcare system, putting just bridges all over the place? Because you can't start from new, because you already have gynecologists, you already have systems, you already have something that the government has established, but at the same time, you don't have actual access to healthcare. So I think that's been one of the biggest struggle in trying to figure out, how does the system work? How do we make it better? And how do we not only think about it locally, but how can we actually make this bigger so that the whole Mexico can actually get access to healthcare? Because right now, Partners in Health is only in Chiapas. And we see a lot of need here, but we're sure that there's so many other places in Mexico with vulnerable population that are going through the same. And how do you really create a system that can be implemented everywhere else in Mexico and can actually function the same way? And that's been just really, really struggling or challenging while we're doing this. So we created the Right to Healthcare program. And again, the most challenging was secondary care, basic surgery, hernias, cholecystectomies, and a lot of gynecological, of course. So I did my research. I went to do my master's program, and try to do a little bit more research on this and try to understand better the healthcare system, trying to figure out a way or maybe an answer to how do we make the referral system work and how do we make patients get access to care. Maybe we can create a system. Of course, it's just harder than doing research and trying to put a simple solution to a really complex problem. But we've decided, at least at the local level, to start a surgery program. And that's when we partner with PGSSC and we start to work together to at least start getting some numbers. So I came with the idea of, we're gonna do surgery, and I know the most required surgery is just basic general surgery. But talking with the hospital director, because we're partners always with the Ministry of Health, so, which is really super important, as Dr. Levy was talking about, just really listening to your partners and really knowing what is their need and not what you think is required. So I came with an idea. I went to the hospital, we started working together, and I kept talking about surgery, and then the hospital director talked to me and she was, you know what we really need, she was excited about the program and everything, but then she was like, what we really need is a gynecologist. So 80% of what we actually take care of in this little hospital are obstetric care. So why don't we bring a gynecologist and actually start an OB/GYN program? And then we did our needs assessment. We talked with a lot of different organizations, a lot of different partners that had started a new surgical program in other places. And that's how we started moving ahead with our surgery program. So I think that's been a great challenge. And I think Sabrina will probably talk to you more about that. She's our gynecologist right now on site, working 24/7, I would say. But I think it's been very interesting to see how complex it really is to start a surgical program, and how many people and how big of a team you actually require to get a surgical program started. Because it's seeing infrastructure, is learning about systems, as we said, it's learning about not only the gynecologist, but then you actually need really good nurses, you really need a good anesthesiologist. You require, we also work with a lot of great midwives, and they take care of everything related to a non-surgical care. You need blood supply, you need supply chain. There's just so many components, and you just have to target. Well, we've been targeting like one after the other to make the system better every time. While at the same time with PGSSC, we've been working and trying to get some numbers to try to not only stay at the local level, but try to present some numbers at the state level and at the federal level to really portray the needs that we have in all the vulnerable populations in Mexico to make surgery accessible to everyone. And yeah, I think I'm going to close with that. So thank you.
There we go. Sorry. Thanks so much, Dr. Macias. That's so helpful to have kind of that local systems level view, and really interesting to hear about the process of, you know, saying, I'm really thinking that we need to identify, you know, ways to get more surgical care and referrals, and the hospital saying, actually, we really need to focus specifically on OB/GYN care because that's what we have, you know, see a great need for now. And I think it's very helpful to have that concrete example actually that flows perfectly from what Dr. Levy was talking about. So thank you for sharing that. And I actually think this flows perfectly into our next speaker, Dr. Cervantes, who can talk a lot about the day-to-day that she's been experiencing as an OB/GYN. So I will introduce her. So Dr. Sarbrina Cervantes Cortes is a 32-year-old Mexican OB/GYN who completed her medical degree at the Universidad Nacional Autónoma de México in Mexico City in 2013. She completed her OB/GYN residency at the Instituto Nacional de Perinatología, also in Mexico City, where she had the opportunity to rotate in London as an observer in the Harris Birthright Research Center for Fetal Medicine in 2018. After completing her medical social service year, post-medical school in the small indigenous community of Chilochla in the highlands of Chiapas, Sabrina was eager to return to Chiapas to assist in furthering maternal fetal medicine practice. Since March 2019 to present, she has been working with the NGO Compañeros en Salud in Chiapas, Mexico, in a global surgery project at the local community hospital, Hospital Básico Comunitario Ángel Albino Corso. She also had the opportunity to participate in an externship in fetal medicine at the Hospital Vall d'Hebron in Barcelona, Spain, in the fall of 2019. Hope I did pretty good with the pronunciation there, but I'm really excited to have Dr. Cervantes here. I've heard so many lovely things about her. I've been talking to Lina quite a bit, so I'm really excited to have her. And I think she did have a few slides that she wanted to share. So I know Anusha was going to go ahead and pull those up for us. And then Dr. Cervantes, is your sound on?
Yeah.
Perfect.
Okay, I will share. Well, good evening, everyone. I prepared some slides for you to share like my experience and how I got involved in global health and global surgery. So I will share with you.
Okay. Dr. Cervantes, unfortunately, I'm the only one who has access to share slides. I have them downloaded onto my computer though, so I'm about to pull them up, and just let me know when you want me to hit the next button, okay?
Okay. So we can start. Thank you.
One moment. You want to go ahead and start talking, and I'll try and fix some of the settings, all right?
Okay. So, well, as Fallah introduced me, yes, I am a Mexican OBGYN. I studied medicine in Mexico City at the UNAM. And here in Mexico, when you finish your medical school, you have to do a social service. So since the beginning of my career, I wish to serve to a community, to a faraway community. It was like one of my dreams. So I had the opportunity to go to Chiapas, to an indigenous community called Chilolja. It was about 2 hours from San Cristóbal de las Casas, which is one of the main cities in Chiapas. And, you know, like every young doctor that wants to go to a community and change the world and change your patient's life, and, you know, you're so enthusiastic, but the reality after all this experience was that the people that really was changed was me. I was really changed my life, the way of seeing my patients, the way of seeing my country, the way of seeing the women in Mexico, how they still live, that most of them don't have the freedom like we have. They don't have privilege like we are. So after all this experience, and also seeing like the difficulties, the social determinants that were an obstacle for a patient to receive a surgery or a treatment. I mean, like, if I wanted an ambulance, I had to ask for it, and it was like 1.5 hours far away. And then when the ambulance came to my community, it was like 2 hours from the closest hospital. So imagine waiting like 3 hours for an emergency, for an ambulance. So sometimes I took the patients in my car and I took them to the hospital. And I know today is like, I think that I was a little bit crazy, but I was so frustrated and I wanted my patients to receive the attention. So as Val said, I didn't know that this was global health. I didn't know that this was my first contact with global health. And also I discovered my passion, that is like the health of the women, to be a companion with her in their pregnancy, to share this special moment with them, to also be a friend of them also, because they share this part of their lives with you that they don't share with anyone else. No? They have this confidence to talk with you. So I really decided that if I wanted to change, well, not the world, but Chiapas, I had to come back to Mexico and study my residency in OBGYN. So I went to Mexico and I studied my residency in a 3rd level hospital, and now it was all the other way around. I could see like the latest evidence to treat our patients. We were a referral center, so we had a lot of high-risk pregnancies. So I really learned how to manage these difficult situations and high-risk patients. And also, you know, like every day we had to read a new article and classes and everything. So this prepared me for my next step in life, that when I finished my residency, one of my friends sent me a job offer, and she told me, this is for you. You love Chiapas, you are a hippie, go and change the world as you want to do it. So I finished my residency on February of 2019, and in March of 2019, I was working in Compañeros en Salud in Jaltenango de La Paz, that is really far away from the capital, that is Tuxtla Gutierrez. We are about 2.5 hours. So I didn't know really what was I going to do there, but I was really enthusiastic, and we were, as Valeria explained before, we were trying to start a global surgery program. Our objective was to all these patients that couldn't receive surgery, like a hysterectomy or a C-section, that we can give this to them, this opportunity to perform the surgery there. And you can say that, and it can sound really easy, right? Like, I mean, I'm an OB/GYN, I did a lot of C-sections in my residency, so why not? I could operate in any place. But this has been like the biggest challenge of my life, like academic and personal, because it's not only about me getting in the OR and operating my patient. No? It's about, you have to be aware of the instruments, of the nurses, of the air conditioning, of everything. So it was like, it was really difficult at the beginning for me because the nurses that worked with us were not surgical nurses. So with my team, we taught them how to be in a surgery, how to dress the doctors, how they have to wash their hands, what instruments were. So we have to start from the beginning. And also, like Val said, like our plan was to make a global surgery program, but the reality was that our hospital, it's about 80% of the patients are obstetric emergencies. And so we also realized that it was not only about doing C-sections, it was also about educating our general practitioners to know how to treat a medical abortion. For example, before I was in Jaltenango, all the abortions were sent to the closest hospital in Villaflores, and they perform a curettage, like, and you could give those patients only misoprostol, and that's it. They don't have to spend their money going to the hospital. You are not going to risk the patient in a surgery that is unnecessary. But of course, the doctors were afraid to give misoprostol if they don't have an OB/GYN there. No? So these and many other difficulties that I've had found here. Also, it's not so easy sometimes that one of your patients can go to a hospital, to a referral, because they have to pay for the ambulance, so it can take them to the hospital. So imagine that it sometimes is really more expensive of what they have for the whole month. No? And when they get to the closest hospital in Villaflores, they have to buy all their material. So imagine this situation. And also sometimes, like, they have a lot of children, so they are very worried because if they leave to the hospital, the children are going to be alone. So it's not about only treating a preeclampsia, it's like seeing all the social determinants for the patient. So performing a C-section here in Jaltenango now has a different meaning for me. It's not only a surgery, it's really a change of your patient's life. It's helping them, it's really contributing to, they have a better condition, the whole family, of course the patient. So in the last year, we performed about 143 surgeries in a really, really small operating room with the help of a lot of people. And well, I am very grateful for this experience and for this new challenge for me. I also have been introduced to the world of global health, to global surgery, and day by day is really very hard work to continue. And also we have, like, in this moment, I have like 40 pregnant patients of high risk pregnancies. And some people could believe that you cannot do a lot of things because you are far away. But for example, I will tell you another of my cases. I had a patient that had a short cervix, about 22 weeks of pregnancy. And I knew that the treatment has to be an emergency cerclage, but how am I was supposed to do a cerclage here, so far away, without mercy lane suture? But thanks to Compañeros en Salud and to many people involved, we could reach the suture, the mercy lane suture, and I performed the emergency cerclage, and 7 months later, we got a baby of 38 weeks. And so during the residency, you don't think that these things are going to be so valuable in your life. But imagine if I didn't have like the best evidence, I would never know that this patient was candidate for a cerclage. So I'm really grateful for all the path that took me here. And thank you very much for listening to me. And I'm open to any question.
Thank you so much, Dr. Cervantes. It's so inspiring, especially as someone who's about to start residency, to hear about your journey and all the amazing work that you're doing. And I think what's really, really wonderful about what you shared is how building these systems actually really helps support you as an individual provider and those patients at the individual level. I think that's so unique to be able to hear the impact that has been able to have on so many lives. So thank you so much for sharing all of that with us. I know we will definitely have a couple more questions, but I'll wait till after we move on to Dr. Roa, and then we'll come back and talk more. Thank you so much.
Parisa, just one moment. I just wanted to say, Dr. Cervantes, I'm really sorry we weren't able to share your slides. I think that, we posted these webinars in the past and they've gone all right, but I think right now there's been a lot of issues technically with everyone using Zoom. So just for everyone else, that is something that we'll be adjusting moving forward to try and facilitate slide sharing a lot better. And I'm really sorry that we weren't able to host it this time, but it just wouldn't be a safe environment, I think, with this number of people on a call. And I'm unable to, personally know everyone on it. So I apologize for that again.
It's okay.
So our final speaker is Dr. Lina Roa, who I know very well and love. She is the Paul Farmer Research Fellow in Global Surgery at the Department of Global Health and Social Medicine at Harvard Medical School. She's also a resident in OB/GYN at the University of Alberta. Her research focuses on inequities around access to healthcare, particularly to high quality and affordable surgical care. She currently works in Amazonas, Brazil, and Chiapas, Mexico, building research capacity and improving quality of surgical care. She is passionate about maternal health, particularly access to cesarean sections and medical education. She obtained her medical degree from the University of Toronto, and she's currently pursuing an MPH in clinical effectiveness at Harvard T.H. Chan School of Public Health. So I will turn it over to Dr. Roa to give us a little bit of her journey and her work with PGSSC and anything else she'd like to share.
Thanks, Parisa. Can everybody hear me okay?
Perfect.
Yeah, okay, good. So first of all, thank you for inviting me. It's fun. I was not expecting 120 people to be joining this on a Tuesday night during a COVID pandemic, but this is awesome. So thank you. And it's lovely to be joined by so many people that I've had the pleasure to work with the last few years. So when chatting with Parisa, she wanted me to highlight mostly my journey as a trainee because I'm still in residency. So I'll just tell you a little bit of what my story has been, highlighting some points that I think might be relevant to some of you. So like Parisa mentioned, I was actually born in Colombia. I grew up in South America, and my family moved to Canada when I was in high school, 15. And as if any of you is an immigrant or son of immigrants or daughter of immigrants, then you know that there's always this feeling of wanting to give back to your country of origin, to the place where you came from. So I think that's where the seed of global health kind of started growing in me. And I went to medical school in Toronto, and I had the opportunity of working there a lot with inner city populations and refugees. So going back to Dr. Levy's theme of local, that was actually when I first started thinking about systems and what's the impact of poverty on health, of injustice, social justice, all of these themes. It was actually mostly through my experiences in downtown Toronto. And then I would say after that, in medical school, I did have the opportunity to do a couple clinical electives. My school had a partnership in Zambia, so I spent some time in Lusaka doing research, as well as in Angola doing some clinical work. And as some of you might have experienced, it's hard to contribute in a meaningful way clinically as a medical student because you just don't have the skills for it yet. However, I realized I felt a bit more useful when I was doing my research elective as opposed to my clinical elective. And I think it was during Zambia when I was studying HIV transmission from mother to child that I realized I really like research, I really like women's health, and that's something that I wanted to do in the long term. Then I started residency, and I had zero free time to do any research, to do any global health work, to do anything. It was my passion, and I knew I wanted to pursue it. It was just impossible to find time for it. So when I heard that my program had the opportunity to take 2 years off to do research, and I know many programs in the US do as well, it's more common in general surgery. Unfortunately, not as common as OB/GYN, but I'm hoping we can start changing that because it's really valuable to have those 2 years to do research. So then I applied for the PGSSC for short. It is the Program in Global Surgery and Social Change, which is based at Harvard Medical School. And so I've been there. It's a 2-year program. I actually ended up staying for a 3rd year because I liked it that much. But in July, I'm coming back to finish my residency in Canada. And so I guess one of the strengths about the PGSSC is they approach surgery from a systems level. So even though I'm an OB/GYN, I was working hand in hand with anesthesiologists, with surgeons, plastic surgeons, ENTs, and not only surgeons, but also economists, policymakers, so that you look at surgery not only from what happens in the operating room, but also what's happening at your town level, at the state level, and then also internationally. So some of my work has focused on quality of surgical care. As you probably know, quality is extremely difficult to measure because it has many different components. So that has been one of my focus. And then if you're familiar with any quality metrics in high-income countries, it often requires like all this complex and sophisticated data collection tools that are just not very feasible in low resource settings. So we've been working on developing tools that are simple to use, simple to implement, and that can comprehensively measure quality of care. That has been one of my projects on the research side of things. And then at PGSSC, we've also had the opportunity to do some policy work. So I spent a couple months at the World Health Organization in Geneva. And then also the World Health Organization has 6 regional offices all over the world. And I got to spend 3 months at the one in Manila. So that is the Western Pacific regional office. So what we were doing there was policy work. So working on a regional framework to strengthen surgical obstetrics and anesthesia care. So it was a completely different experience from what I was used to. It was more thinking systems and how do we develop systems and frameworks that are going to work in the case of the Western Pacific region is something that has to work both for a country as big and as developed as China, but also as small and rural as like the Pacific Islands, Tuvalu, Vanuatu. So it was a very good experience, and it helped me realize that even though what we do as physicians has a huge impact at the patient level, we still need to work with policymakers to help them understand and to provide them with evidence so that they can make the best decisions so that we can have public health and impact at the public level, at the large scale, I would say. So those are some of my experiences. As you've seen from the last 3 years, it's been mostly research and advocacy and much less clinical work. But I'm sure there's going to be tons of opportunities to be involved in more direct clinical work once I'm finished residency and once I have the skills to contribute in a more meaningful way in global health. But I'll keep it short and then happy to answer any questions.
Awesome. Thank you so much, Dr. Roa, for sharing. That really helps us actually kind of wrap everything together, starting from professional societies, moving on to systems, speaking at the local level, and then kind of how that all plays itself out at the policy level when working with governments. So thank you for sharing. And I think that actually goes perfectly into our first question for our panelists. Before I start, I know we started a little bit late because of the technical issue. If our panelists are amenable, we'd be happy to go for an extra 15 minutes. But of course, if any of you need to leave, absolutely, please feel free. So the first question that we had was, how do you see OB/GYN within the current landscape of global surgery? And, feel free for all 4 of our panelists to speak from, whatever perspective you come from.
I'll start. And just to say, because I've been thinking about this a lot, I mean, when you think about it, the experience in Mexico is exactly what we see in the rest of the world. If you have a system that can do emergency cesarean birth, you have a system that can do surgery. because all of the things need to be in place. You need to have anesthesia, you need to have blood, you need to have sterilization, you need to have nurses, you need all of that structure in place. I think, unfortunately, OBGYNs have just not had as loud a voice and as much of a presence at the table in the global health community that has been addressing surgery. So we tend to take people have talked much more about trauma than they have about cesarean birth. And very frankly, a couple of years ago, I was the only women's health advocate at a table full of men talking about trauma and orthopedics and all these other things. And I'm saying, yes, but what about cesarean birth, that we need to prevent fistula and we need to be able to provide the best care for women. So I think there's an opportunity when Dr. Roa can, take over and do her policy work and sit at the table and incorporate all of you to have loud voices about women matter. And it may not be as sexy to think about cesarean birth, but that's the foundational surgery that we should be planning everything around. And it's very unfortunate, but in the US, the American College of Surgeons has a bigger footprint than the College of Obstetricians and Gynecologists. And I see that sort of worldwide, that we've got organizations of surgeons that may include gynecology sometimes, but we have not taken a leadership role. Part of that is because babies are delivered by midwives in most parts of the world, and that women don't have access to specialists in surgery. Often the C-sections are done by medical officers who have a year, maybe, of general medicine training, and their skills are not there. And they actually, in some parts of the world, are causing more fistulas than they're preventing. So we have a lot of challenges, but I think the biggest challenge is for us to speak loudly with a uniform voice that says to the world, global surgery means global access to cesarean birth, and creating the system structures for safe cesarean delivery will de facto create the systems for trauma care and everything else.
It's just to hear that. Anyways, I'll let Dr. Macias.
No, I wanna complete that as what Dr. Levy was saying. When I did my research, so my question was how many patients that actually require a surgery get a surgery, and it was less than 40%. And when it was an elective surgery, because they end up being emergencies afterwards if you don't take care of them, it was around 30%, 32%. And we're talking about patients that actually made it to the hospital. And then of all these patients, the ones that struggled the most were actually women requiring what I'm gonna call, again, elective surgery. I like to put quote unquote on that, because having your uterus outside of yourself, for me, shouldn't be an elective surgery. So it just takes forever for women. And I want to advocate not only for C-sections, because I believe that sometimes it is very important. And don't get me wrong, I do believe it's one of the most important things that we need to take care of from the surgical perspective. But also there's so many forgotten women with gynecological conditions that no one is talking about. There's just so many women struggling, and there's just, we need to advocate more for them. I love when you said we as women need to, talk about it and say this is important. And even when we're talking with the with the Ministry of Health, the personnel from the Ministry of Health, and we were advocating for, we need to have hysterectomies, we need to use even other, maybe using, sorry, I forgot the word, the pessaries, even pessaries, just using pessaries. And for, of course, as you mentioned, a lot of the times it's men, the ones that are right now in power as the ministers of health. And I don't want to go into that, but they were openly telling me there's no woman that require this. We've never had patients about this, and it's so complicated to use pessaries in rural settings. And I pushed and pushed and pushed and took him to the community and was like, we need to talk with this woman. And then they started realizing that there is a huge need. And then they started being more open to, okay, maybe there is a possibility that we can start doing this types of surgeries in more rural settings, or bring other types of equipment that could be useful for a lot of the women. Maybe it is a necessity, but we just haven't seen it because no one is talking about it. So I do believe we need to do a lot more to help women have quality of life. And I think the other one that I was going to talk about was also, I would love to also see more programs. I know it's challenging and it's not easy to have exchange, like clinical exchange of people, but I would also love to see more. When we were starting the surgical program, there are a couple of fellowships that do accept clinical exchange. We usually have family doctors, internal medicine physicians, pediatricians, but it's so hard to get people in the surgery environment to have this clinical rotations. And it was even more challenging to have OBGYNs or anesthesiologists. So I would love to see if we could encourage more good universities with really good high quality programs to give some of it, because I know it's expensive, but give some of those resources to do global health and to do global work for their residents or for people. Actually, some of the ones that I know, they're not residents, they're actually people that have already finished their specialty and that they want to do a fellowship. So I think I would love to see more of that so that we can actually get those training exchanges for our staff. I would love to train our staff to do more in the surgery room. Yeah, thank you.
Francis wanted to add anything, but just like, yes, you know, like just hearing both of you speak. I mean, it's funny because a couple members of my team, and I'm sure many of the people on this call know that this is a topic I'm particularly passionate about. So I love hearing that, you know, there's so much unity in thought around the important role, basically the foundational role that OBGYN plays within the field of global surgery, and that we're just not being given the opportunities to speak up. And I think that means that we now have to move forward and take those opportunities for ourselves. So I really appreciate this.
So I think you're right. It's speaking up, but it's also funding.
Yes.
So, you know, the foundations and the funding is much more directed towards ENT surgery, fixing cleft lip and palate. It's not about the mundane things of the real world, like a uterus falling out or a baby that can't get born.
Right.
And somehow we've got to reach funders to say, this is foundational. This will create the structure for global surgery.
Yeah.
If we can build it for OBGYN.
Absolutely. Very, very important component beyond the advocacy piece, of course. So just looking at how much time we have left and the questions that we have from people. So many really lovely questions from the people who registered. I think a lot of people had questions about the role of trainees in these kinds of initiatives and the types of systems building work that you all have talked about. And knowing that many of the people on this call are kind of in that bucket, it'd be really lovely to hear from all of you about what do you think is the role of trainees in global OBGYN initiatives and leadership? If anyone would like to speak to that.
I think that, first of all, it's really incredible that you are here and that you are interested and that you have this opportunity in your country to, besides doing your residency, you can do research, you can get involved in global health. And I think that, for example, in Mexico, it would be lovely to share this kind of events with our residents, because I can tell you by my experience that I didn't know that this whole world existed, that there were masters and that there were people really working for everyone receiving a surgery, So I think that the first step would be like to share your experience, to share the knowledge, and as Val said, like to have more opportunities to do external rotation, because I'm sure that everyone that is now in the residency would love to attend labors and to do C-sections and to have this experience, and also to get involved with your patient, because it's not only about doing surgery, it's about really getting close to your patient to understand her. So I think that first of all, well, share, and another advice would be like, learn the best evidence that you can every day. I used to say to my residents, well, here in Mexico, it's like you have night shifts like every third day. So everyone says that one more night shift is one less night shift, right? And I told them that one more night shift is one more opportunity to have a case of a patient that maybe you won't see until you are alone in a faraway place. So I would tell you that live and enjoy every night shift, enjoy every patient, and learn as much as you can. So when you finish your residency, you can go to the world and make a difference in your patients, even though they are in a faraway community or they are in the city, in any place that you work. So, thank you.
I will just add to that. In addition to considering clinical experiences, which is what I think most students think of when they think of global health, think outside the box. So think about research and policy, and research it could be being in a hospital and collecting data, interviewing patients. It could also just be sitting in your computer doing some economic modeling that can inform policy and can inform guidelines and things like that. So don't think that the only way to get involved in global health is to go and do clinical work. As I'm sure many of you have heard, you have to be very careful how you choose the partners that you go with, make sure you're causing no harm, and follow all the other principles that Dr. Levy talked about. That's crucial. But then seek other opportunities. I don't think I realized until residency how many different ways there are to get involved outside of clinical work, whether that's just advocacy. Advocacy, you can do it from home just by being well informed and writing articles, speaking up, going to conferences, or doing research that will inform policy, doing research about topics that are under-researched, creating research capacity. A lot of clinicians in low and middle income countries don't have the luxury that many of us have in high income countries of having an undergraduate degree, of having entire summers spent doing research, of having protected time for that, of having funding for that. So there's lots of other opportunities outside of the clinical work where you can have an impact, you can learn a lot, to just be open-minded and seek those opportunities.
And I just want to reinforce the ethics of trainees going to places and essentially learning on an underserved population. So in order to make that an ethically appropriate rotation, it means faculty have to go as well, and they have to be there supervising. And that's a huge resource allocation for most universities or most programs to be able to do. So I really want to reinforce what Lina said, that there's great opportunity to do research, to go and learn a great deal without having to be operating or delivering babies, but to learn a culture, to learn about care delivery in different systems is a great opportunity.
Mm-hmm.
And I think that actually flows really well into what might be one of our last questions, our last 1 to 2 questions. Something that came up from a lot of people was, how can some of the lessons from global OB/GYN, and I think they were referring more internationally, be applied domestically to deeply rural, low resource communities here in the United States? And I know, Dr. Levy, you had brought up global. So I don't know if you'd like to start, and then if anyone else can speak to that.
So, you know, what we've learned over the years is that care delivery is a team sport, and that we don't have unlimited resources, and we're never going to have enough OBGYNs in the United States or globally to get care into every town, every community, every health center. So engaging community health workers, having local people identify solutions that work for them, communities that know what their barriers are, and then being able to work together to solve those problems. It really is implementation science. And using those same principles of preparation, of asking the right questions, of quality improvement, those are applicable across the world. And it's really a question of engaging the right partners, figuring out who they are, making sure that there's a huge representation of the community that's being served, and that they are driving the implementation, that it's not the top down, it's the bottom up. Because I think a lot of our issues in the US are issues of trust, and they're totally understandable. We have abused the Native population, the African American population. No wonder they don't trust us. And so the only way to really begin to get care that's appropriate into their communities is for them to drive it, and for them to say, this is what we want, this is what we need, these are the outcomes that we're looking for, and how can you help us get those?
Absolutely.
I think also understanding that a lot of the root causes behind poor health outcomes have to do with the social determinants of health, have to do with racial discrimination, with colonialism. And so I think understanding that helps you bring the global context locally. So the reason that African American women have higher maternal mortality than white American women, if you go deep down, it's racism. And it's that same racism that means that women in sub-Saharan Africa are more likely to die than a woman in Canada or in the US. So I think going beyond the clinical and understanding all those root causes of injustice can help you be a better clinician or policy or researcher, both abroad as well as at home.
And a better advocate.
Yep.
Absolutely. Thank you guys so much for sharing that. I think it's really important for students and trainees, particularly for those of us that are here in the US, to understand that global health has a very broad definition, and that it's important to look not only at the healthcare systems, but also the structural systems that have kind of determined, unfortunately, the health outcomes for different groups of people. So really appreciate you all sharing that. I think it's 10:13, so I think this will likely conclude our webinar for now. I know that a number of people submitted questions about how can future OBGYNs get involved in global health, and how do I apply for residency looking for global health programs. Just having gone through that literally a couple months ago, what I'm going to try and do is put together a couple of answers to help those students just get a sense of the landscape out there and how to advocate for your interest in global health and how to identify programs that would support you. So hopefully we'll get that out soon. And I just want to kind of conclude by saying, first of all, thank you to the GSSA education team. Natalie, Nancy, and Andrew, who really helped put this together. Anusha, who manned the Zoom through some very challenging situations today and did an excellent job. To our panelists for making time and staying a little bit extra, and for just phenomenal presentations and answers to students' questions. And just to say that, in global surgery, it's really important that we think beyond general surgery. There are so many more components to the field of global surgery, some that are foundational, such as OB/GYN, but other subspecialties, other different niches as well. And so for the Global Surgery Student Alliance, it's really important that we want to highlight those different aspects so students remember that there's a lot more to the field than just what meets the eye. So thank you so much, everyone, for being here. And Anusha, I don't know if you had any final thoughts you wanted to share, but thank you, guys.
No, I appreciate everyone bearing with the technical difficulties today. It's definitely something that we're going to troubleshoot and fix for all the webinars moving forward. We'll just probably have to have like a more secure method of disseminating the information. So really, really appreciate everyone bearing with me. Apologies again. And hopefully this is something that doesn't happen in the future, but I am really excited. We have a lot of, really great talks coming up, not just from GSSA, but I think across the board. Universities and institutions are putting together some really great online initiatives, and we'll try and share them as often as possible on our Twitter. So definitely follow us on there if you want to keep updated on other global health and global surgery related topics that are coming up that are available online. And we just hope everyone stays safe during this time. If you need anything, or if you have any ideas for any other events or support that we can provide, definitely feel free to reach out to us. All right. All right. Thank you, everyone, and have a good night.
Thanks.
Good night.
Thank you. Bye, everyone.
Thank you.